All right, hi. So we're going to start our discussion on diseases and conditions of the integumentary system, chapter 6. As a reminder, this is what normal skin looks like. Skin also includes the accessory structures within skin, like our hair, sweat glands, the erector pili muscle, which allows our hair to stand on ends, the sebaceous glands, which secrete the oily sebum that lines our skin, as well as all of the receptors like your Pacini corpuscles, Ruffini's, etc., that sit within the skin. Reminder, skin also has 3 different layers to it. You have your epidermis, dermis, and subcutaneous layer. Terms used in common skin lesions are summarized here. You will often see these words. They do, in fact, have completely different meanings, so it is important to recognize them when it comes to identifying different conditions. More common skin lesions here. These ones are a little different, but this information is summarized in table 6.1 in the textbook. So, first condition, dermatitis. This is a generic inflammation of the skin. There's many different forms, many different causes, but the main thing is that you're going to see pruritus, erythema, and various different types of cutaneous-based lesions. So, seborrheic dermatitis. This is one of the most common skin disorders and is inflammation of your sebaceous glands. Remember, sebaceous glands secrete sebum, which is the substance that makes skin oily. These are realistically located all throughout the body, but they are in large numbers on the scalp, face, around the nose, ears, and in the middle of the chest. You'll get reddened skin, a greasy yellowish appearance of the skin as well. Cradle cap, as it's called during infancy, is one common presentation of this. This is a generic look of what it looks like. It is idiopathic, meaning that it's not fully understood why it happens, but it's believed to be related to a yeast-like organism called Pterosporum, which is found on the skin in rather small numbers. So, this information is not very conclusive. In most patients, though, further lab testing is not all that necessary. Typically, though, you want to use low-strength corticosteroid creams. There's also prescription shampoos and non-prescription shampoos. And for cradle cap with an infant, you'll also perform a gentle massage. Key thing with things like corticosteroid creams, you don't want to use them too long because you actually can have a skin withdrawal effect of the corticosteroid cream, which essentially causes your skin to slough off. Contact dermatitis. So this is acute inflammation triggered by something touching the skin. This is essentially a type of allergic response, okay? You're going to get some redness, some swelling, and you might have oozing vesicles that pop up on the skin. Okay, this is what it looks like here. So there's 3 main different ways that it develops, but it's often related to items like perfumes, soaps, para-aminobenzoic acid, PABA, and certain types of medications like tetracycline can sensitize the skin to sunlight, which can also be another way that this is caused as a photoallergy. Treatment, realistically, you clean the area and stop exposing the skin to the triggering substance. In severe cases, you might take a corticosteroid cream or a oral Medrol pack, a methylprednisone, which is a corticosteroid, for several days, about a week or so. Eczema, atopic dermatitis. This is chronic inflammation that typically is related to family history when you have a family that has lots of allergies. There's typically a characteristic pattern of rash on the face, but you can also see it in the neck, elbows, and trunk of the body. It is considered idiopathic, and it has lots of different contributing factors. Individuals can have flare-ups of eczema from stress, anxiety. You could get into an argument with a friend and have an eczema flare-up. In reality, treatment involves removing those stressors And eczema can't really actually be defeated by medication as of this moment. So this is what atopic dermatitis looks like here. Urticaria, these are hives. So these are associated with severe itching and an area of swelling that's termed a wheal in the localized area of the skin. You can have gastrointestinal versions of these that result in what is commonly called colic. You can also have hives that develop in the pharynx of the throat, which can actually cause the airway to become obstructed. These are often acute, self-limiting, and don't last very long. But again, if they're occurring in the throat, they can be life-threatening, and it can also be life-threatening in certain locations if it's presenting as angioedema. Most common forms of this are related to things like food, insect stings, etc., like your bee sting, and ingesting food like peanuts if you have an allergy. In reality, the best way to avoid it is avoid the factor that causes it to happen. Antihistamines are typically one of the best ways to help minimize symptoms. But again, in more extreme cases, if you're having a higher grade hypersensitivity response, you may actually need like a rescue medication, something like an EpiPen. Psoriasis. So psoriasis is a rheumatic condition that's characterized by thick, flaky plaques that grow on the skin. You can see what they look like right here. The skin's going to look dry, cracked, again, scaly, right? Psoriasis is common on the scalp and the extensor surfaces of the body. So this is areas like the back of the wrist, the elbows, the knees, and it can even occur on the trunk of the body. Some psoriatic locations are associated with physical trauma. About 15% of people that develop psoriasis develop psoriatic arthritis that we have mentioned in a the musculoskeletal lecture. It is one of the primary inflammatory arthropathies. Psoriasis is generally treated by a rheumatologist. It's one of the only conditions that really has this type of look. One of the more interesting methods of treatment for this is actually the use of ultraviolet light. You might also see drugs like methoxylin, which helps enhance the effect of UV light, and various other creams that can also help. There's not really a cure, but there is some evidence that vitamin A supplementations, because of the retinoid substance, the retinoid relationship with vitamin A, and antihistamines may also help as well. Some individuals also will take corticosteroids orally, but I believe that they do try to keep the corticosteroids as a topical. Acne vulgaris. Everyone knows what this is. This is your standard acne, right? Commonly associated, with stress, puberty, etc. This is another inflammatory condition related to the sebaceous gland. It's not an emergency, but it can be rather stressful for people with it, and it does help it helps to potentially increase risk of infection as well. There is some hereditary factors to it, and this is what it looks like. Typically, therapy is going to be topical or systemic antibiotics. There is some literature that says that certain certain bacteria might actually be linked to acne, but there's no definitive evidence for this. But they still use antibiotics because for people that have a lot of these lesions on their skin, they again are at greater risk of developing an infection. Herpes zoster, so this is shingles, kind of like the adult version of chickenpox. The big thing with this, though, is that the herpes zoster virus actually resides in the nerve tissues of the body. It goes dormant and it hangs out there until it flares up. The first symptom that the person starts to experience is pain in a dermatomal fashion. Okay, so as you'll see here, dermatomes. Dermatomes are not a 100% consistency between everybody, but there are standard patterns of the body's development. And the concept of dermatomes is that for instance, using our C3 dermatome as an example, the nerve that comes out of the nerves associated with the third cervical level will innervate very specific areas. There's a little bit of overlap between all these guys, and there is different variation between people. But once the pain starts, 24 to 72 hours after, you will actually start to see vesicles emerge in that same dermatomal pattern. Shingles does have a vaccine that's available, and it's typically given to individuals that are much older, as herpes zoster is not a major problem for young, healthy people. It can be painful, but in older individuals, it can wreak havoc and can become more of a chronic, major problem. As this is a virus, there's not many direct treatment options, but because it does cause nerve pain, you might see the use of things like mild tranquilizers, nerve block type injections, and in severe cases, the person can also have something called post-herpetic neuralgia, which basically means pain persists even after the condition has been treated. Next, cellulitis. So cellulitis is a bacterial infection of the skin and subcutaneous tissue. What you start to see looks just like this. A lot of swelling, redness. You might even see blistering. And it might actually start with a streak of red radiating from the initial site. Typically, this is caused by your Streptococcus or Staphylococcus bacteria that enter the skin. Those two bacteria are two of the biggest problems that we have as a human species. They absolutely love to get into the body and wreak havoc. They also naturally live on our skin, live in our mouth, live in our GI tract. So it's almost a love-hate relationship with these guys. So treatment, you immobilize, you elevate. All right. They might use different type of compresses, and massive systemic antibiotics are often used to handle the infection. One big thing also is that hospitalization may be necessary if the cellulitis is severe and is showing signs of systemic spreading. Next, dermatophytoses. These are basically the common term used to describe superficial skin fungal infections. As you can see on this list here, there's different names for it. They tend to name it for the region of the body. While this is not generally considered a major issue, the patient likely does need treatment a little quicker than other cases. So tinea capitis, this is on the head. Tinea pedis is on the foot. Typically, though, you get symptoms like burning, you get that redness. You might even have, like the foot shows here, open sores. The infection is spread by direct contact of the fungus, so it is important to practice proper sanitation, especially if you are interacting with this person or you have like a family member with one of these things. There are shampoos that have high levels of a substance called selenium sulfide. Those can be prescribed. Some of them are available over the counter in lower levels. There's also sprays that are available over the counter and topical, and there are prescription strength versions that are available as well. Decubitus ulcers. So these are your pressure ulcers, your bed sore. The person has laid in a bed too long, and the pressure on the skin has caused the skin to necrose. Typically seen in individuals that have prolonged hospitalizations, and specifically people that have difficulty moving themselves. The That's why there are strict protocols in place for a lot of these patients in order to help prevent these, because in a lot of the patients that end up with these, they're ultimately now at severe risk for infection because they're already not in good health, typically already very weak because they can't move themselves, and now they have this massive open sore on their body. Treatment, topical agents, and you may also use patches with antibiotic materials. They might also need to debride, and antibiotics are also typically used. A lot of times these are treated rather aggressively because, again, a patient that has a pressure sore is a patient that's already likely very sick. Generally, though, the best way to treat it is to actually prevent, which is why change of position at least every 2 hours and having the patient engage in range of motion type exercises at an absolute minimum is necessary. Next, scabies and pediculosis. These are mites and lice. These are parasites that infect the human, and they're rather, I shouldn't say common, but I think everyone, knows people that have at least had one of these things. Contrary to popular belief, they actually prefer clean skin. There was always kind of the myth, I know growing up, the myth was that only dirty people got scabies and lice. But in fact, they thrive better on clean skin. Most common symptom you're going to see, though, is an intense pruritus and sensation of stuff crawling on the skin, because there literally is a parasite crawling on your skin. Scabies tend to have a much more intense type itch, whereas lice tend to develop a rash, and you might see things like nits on clothing. They're just spread by close physical contact, so it's important to remain separated from people with these conditions. So for head lice, there is a special shampoo that you use for at least 7 days. You do lots of meticulous combing to dislodge any of the nits, soap and water, etc. Scabies, again, special shampoos. Sulfur preparations tend to be effective at helping kill these off, and topical steroids may be useful in order to help with the itching. Next, benign and pre-malignant tumors. So the 4 things listed here are some of the most common versions of those. These, remember, are non-cancerous growth and tumors. They are typically a cosmetic problem only, but there is a chance that some of these actually can have a malignant transformation. So the first one, seborrheic keratosis. These are benign growths that are from the epidermis, typically are asymptomatic, and typically in very elderly individuals. This is what they look like. Next, dermatofibromas. These are often in younger individuals, more common in women as well. They can be found anywhere in the body. They're thought to be caused as a leftover reaction to a viral infection, and they might be a little raised, but typically scaly and hard growths. This is what they look like. Next, keratoacanthoma. Unfortunately, these are epithelial growths. They're often a papule with a central crust, which makes them look a lot scarier than normal. They do need to be differentiated with squamous cell carcinoma, as you can see from this picture. And they often do scar, unfortunately. But again, benign, pre-malignant. Keloids. Keloids are basically your scars. Keloids are often secondary to trauma or surgery. Most keloids aren't a problem. Typically, keloid will appear normal, but they can become noticeably larger and thicker. They can also extend well beyond the wound site, and they actually won't regress spontaneously. The difference between that and hypertrophic scar is that those do not extend and they stay right on the site. Okay, so a hypertrophic scar and a keloid, slightly different in that regard. These things are considered harmless, but they can be pretty nasty, like the one you see here. Next, epidermal cysts. These are rather common. These can develop typically over a rather large time, but they're usually painless and typically harmless. They're going to be palpable, relatively movable, and their size range is going to be massive. They're commonly found on the face, scalp, around the ears, and on the chest. Now, a major concern with these is if they are punctured and bacteria get inside, that can cause inflammation and leads to an infection, which can be a problem. So, skin tags or acrocortin. So these are benign. They're growths typically associated with areas of friction like the neck and axilla. The neck because of shirt collars. You typically see them more in men that wear collared shirts. But women can also get them on the neck as well. The axilla and inguinal area is also super common. They are typically a little darker color than the skin that they're around. And there's also some association with conditions like diabetes and obesity with these developing. So actinic keratosis. This is rather common, but it can be a concern because it is a premalignant lesion associated with UV exposure. As we all know, skin cancer is commonly thought to be related to overexposure of UV light. But again, this is a rather common condition. So this is what we look like here. It's going to be scaly looking, kind of rough, browner appearance. So treatment of these guys, seborrheic keratoses are treated with cryosurgery and curettage, basically meaning they either freeze it off or kind of cut it away. Dermatofibromas, they will surgically excise them if they are a symptomatic problem. Keratoacanthomas are treated by surgical excisions, and keloids are treated with corticosteroid injected directly into the lesion to essentially help reduce inflammation and kill it off in a way. Now, non-melanoma skin cancers. So there's really three types of skin cancers to talk about. You have your basal cell and squamous cell. First one we're going to talk about is your basal cell carcinoma. They tend to be smaller. They kind of look shiny, pearly white, pink. They will bleed, heal, and reoccur. That sets them apart from these other guys. And they often have an indented center. Basal cell carcinoma also does not often metastasize. This is what it looks like here. That indented center that bleeds helps separate it from other lesions. Squamous cell carcinoma are typically crusted scaly areas. So they form and can develop really in anyone in areas of sun exposure. As you'll see here, it kind of looks like actinic keratosis, but it's a little bit bigger. This hyperkeratosis is the primary way to distinguish it from basal cell carcinoma. For both of these guys, you will need to do a biopsy, typically a punch-style biopsy. They use a special tool, and it excises a small piece of the skin, and they send that to a lab for examination. But with both of these cancers, again, it's related to UV damage. UV damages DNA of cells, so as cells divide, they become damaged by the UV rays, and that leads to that damaged DNA continuing to be replicated and passed along. And if enough DNA is damaged, you end up with the dysfunctional cells that cause these skin carcinomas. Typically, though, they're going to do surgical excision, cryosurgery. There's also things like electrodissection to remove them. Generally, though, for these two guys, non-melanoma skin cancer has a 95% 5-year survival rate. Squamous cell carcinoma can have a worse prognosis than that if it occurs on the lip, ear, and scalp, or if it's larger than 2 centimeters in diameter. But again, the best way to prevent skin cancer is to minimize excessive UV exposure, avoiding things like sunburn, and using your sunscreen and shade and other strategies to prevent this exposure when possible. Now, the big guy here, malignant melanoma. It's the most serious of these types of skin cancers, but luckily it's not as common. Malignant melanoma is related to melanocytes, which are what create the substance melanin, which creates our skin color. Melanin also has other functions in the body. It is a light reactive protein. So you'll also see it used in other areas of the body that need to react to light, such as the eyes, where we have cells called melanopsin ganglion cells, because they rely on melanin as well. There's also hormones related to melanin, and in the world of melanin is actually rather interesting. Big thing with malignant melanoma, typically a solitary lesion. They're going to be quickly growing. They're going to be very different looking than the rest of the skin around them. They're going to have odd borders, irregular shapes. Often there is elevations in the skin. So this is a rather generic looking version of melanoma, but it can be different shades. Unfortunately, melanoma is typically easier to see on lighter skinned individuals, but it can still be easy to identify on darker skinned individuals with a fine eye for detail. Because again, it's still going to be a completely different shade than the area around it. Again, sun exposure, UV lights. As we'll talk about on the next screen, you're going to look for your ABCs of melanoma, okay? Treatment generally is going to be rather aggressive with a surgical excision with rather wide margins. In fact, sometimes they'll take a lot more than they need to. The 5-year survival rate is about 90%, but if it metastasizes, which melanoma does do, if it metastasizes, survival is often under 20% at 5 years. So, helping identify and screen yourself, your ABCDs, asymmetry, okay? So if you see asymmetric lesion, that's a red flag. A border that is irregular, notch, scalloped, etc., whatever descriptors you want to use, that's a red flag. Color, if it's a vastly different color than the surrounding skin, or the color has changed rapidly, that's a problem. Diameter, most melanoma is actually greater than 6 millimeters. Typically, though, a lot of the time, lesions greater than 2 millimeters should probably at least be looked at by a healthcare provider. And evolving, meaning it's still changing, right? You might check back on it, you might have a spot on your back. A week later, you get out of the shower and say, oh, wow, it used to have a completely different shape. That's also a big red flag. These melanoma can change rapidly. You might also have evolution of new symptoms from the area, like itching, bleeding, crusting. All of those things are a problem and definitely need immediate, not emergency, but, next time you can see your primary care or dermatologist, you need to get in, okay? Abnormal skin pigmentation. So in the same world of melanocytes, we can have non-cancerous dysfunction of these. So the first one is albinism. The body basically does not produce melanin. These people are going to be incredibly pale. They have whitish hair and generally pink to pale blue as an eye color. Albinism can affect all races, all cultures, anywhere in the world. People with this condition do typically have eye problems because you do need melanin in the eye to help protect the eye. Typically associated with things like myopia, which is myopia and hyperopia are your far and nearsightedness. Astigmatism, nystagmus, strabismus, which is your lazy eye, and photophobia. So people that are afraid of light, because typically light is painful. So this is what somebody with albinism looks like. You have that reddish eye color, very pale skin. Another one, vitiligo. These patches, they can change in size, they can change in shape, but you get incredibly pale, irregular patches of the skin. Interestingly enough, commonly happens on just one side of the body. A lot of kids develop this following stressful incidences. There is no cure, but some people do use cosmetic powders, makeups, stuff like that to help cover it up, especially if it's on a typically an exposed area like the face. Now, verrucae, warts. These are rather common, and we have 3 general types. There's your common wart, planar wart, and flat warts. These are a hyperplasia of the epidermis. Typically, they're small, hard, white to pink lumps with a cauliflower-like surface. Most likely appear on areas of thick skin, like your hand and soles of your feet. The common wart, which is aptly named, does make up about 70% of all cutaneous warts. So these are caused by virus and spread by touch. The skin shed from the wart is contagious. There are tons of over-the-counter remedies that are available, like creams. Nowadays, you can also treat warts with like freezing type substances that they have over the counter. And if you do see a physician for it, they will typically do a surgical excision or a cryosurgery or electrodissection to remove them. Nails. Nails and hair are actually one of the more interesting areas of the integumentary system because they provide us a lot of insight into a person's overall health. You can actually catch some subtle changes with these pieces of anatomy that are related to more systemic like diseases. So as you see here, spooning of the nails is associated with iron deficiency. You get nail clubbing from congenital heart disorders, lung disorders, etc., because clubbing is a result of insufficient oxygen getting to the nail bed. You can also have changes in your nail bed coloration. Things like lupus and dermatomyositis, which are rheumatic diseases, actually can cause splinter areas under the nails. White nail beds can be caused by chronic hepatic disease, and again, just general examination of these areas actually can provide a lot of information. Now, luckily for us, nails that are damaged and injured can grow back in a total of 9 months to a year. There will be times where nails can be damaged and they actually do need to be completely removed. With that in mind, it doesn't take all that long for them to come back. And that is everything for our integumentary system.